Ma'am, we're good to go. Ma'am, we're good to go.
Thank you. So, one moment. Good evening, everyone. A very warm welcome to all of you. First of all, let me start by thanking you for your patience. As we start the webinar today, I would like to thank at the onset IDA Mumbai chapter for collaborating with Superfoods Valley, Gurmok, for the webinar on revitalizing metabolic health, the gut-centric approach. I'd now like to introduce Zamrut Patel. Ms. Zamrut Patel needs no introduction. She is the chapter convener at the Indian Dietetic Association Mumbai chapter. She's the chief dietitian in nephrology. She's the registered dietitian with the Indian Dietetic Association. And she's definitely a pioneer for renal health in Bombay and globally as well. Zamrut, I now hand over to you.
Thank you, Sheetal. Very warm welcome on behalf of the Indian Dietetic Association Mumbai chapter. I welcome all of you and I wish all of you a very happy National Nutrition Month. Friends, it's a very good start for us. We are starting with a very good program today in the Nutrition Month. And this year's theme, it's a tongue twister, but the theme is very important. It says, Suposhit Bharat, Shakshar Bharat, Shashakt Bharat. Basically, you need to educate, you need to empower people and have a very healthy nation. And for this, the government has given us guidelines as to what are the different types of activities we can do in this month. As nutritionists, I think we all should focus and do these activities. The activities can be on breastfeeding and complementary feeding. We can do screening camps to see the nutritional health of our young kids. We can take into consideration the different tribal habits and the health and the nutrition aspects in these tribal communities. So as IDA Mumbai chapter, I urge all of you to plan activities, do this activity in the full month of September, and please send these activities in a PPT format so that we can share it on our portal and let all the other members also know that who are the people who are really working hard to spread awareness in this nutrition month. So today's topic is really a very relevant topic because we have a lot of issues with this gut health today. And we have an eminent speaker with us, an eminent panelist with us, senior people who are going to be sharing their knowledge and guiding us further. So not standing between you and the speakers and the panelists, I hand it over to Sheetal. Thank you.
Hey, Zamrut, thank you so very much. I'm sure everybody is all excited for the upcoming National Nutrition Month and everybody is planning their activities. I'd like to now introduce our speaker for the day, Dr. Jayashree Tolkar. Dr. Jayashree Tolkar is a leading bariatric surgeon of Asia. She has received multiple national and international awards right from 1995. She has studied from Pune University, BJ Medical College. She has 25 years of experience in surgical practice across India. She's been part of the SAARC group and Asian countries. She's treated and operated on more than 1 lakh patients till date. And she's got an award for the International Center of Excellence in Bariatric Surgery from the American Association and Surgical Review Corporation. She received multiple international awards from American Society of Bariatric Surgery, International Federation of Surgery for Obesity, American Diabetes Association, and SAGES. Active in clinical research and has multiple publications in the index International Index Journal. She's received the prestigious Vivian Foenska Award for Innovation in Surgical Treatment, Type 2 Diabetes from the American Diabetes Association in 2016. She's entered the Limca Book of World Records in 2005 for 46 hernia operations in 10 hours, and record is still unbroken. She's active socially and has been awarded with social work by dignitaries, the director of JT Foundations, Joint Obesity Solutions, and Indian Institute of Metabolic Sciences. She's conducted more than 500 public health awareness programs and 500 doctor education seminars throughout Maharashtra and across India. She's formed the Obesity and NCD Task Force for the state of Maharashtra. She's initiated a campaign of fight against childhood obesity for the Rotary Club and has worked with 3.5 lakh students across Maharashtra in more than 10,000 schools. She's also authored the book, The Obesity Mantra, which is an awarded book by the Maharashtra Literature Academy 2019. And last but not the least, she has been awarded in 2012 the ASMBS International Award for her poster on gut microflora and obesity, and if they are related, and the impact on sleep gastrectomy on gut microflora. Thank you so very much, ma'am. We are truly humbled to have you here. Thank you very much.
Thank you, Sheetal. Am I audible?
Yes, ma'am.
Okay. So thank you very much, Dr. Saloni, Sheetal, Zumrud, Sukhada, and all my friends from IDA. It has been really a great association between the nutrition and the medical science, which is giving us a lot of understanding about the diseases and the typically so-called diseases which were not supposed to be cured a few decades back. I think together we have to win a lot of things, and I'm very happy to be a part of this program. So coming to our discussion, we are talking here about the metabolic health and how we can revitalize it with the gut-centric approach. As we all understand, there is a gut-brain axis which plays a big role in terms of giving signals from the digestive system towards the brain, and it leads to a lot of neurological functions, complete environment of the body, the vascular health, the mood swings, the mental health, and it is a very, very close and strong association. So if we want to change anything in terms of the diseases, the digestive system, the neurological system, or the metabolic system, we cannot neglect the health, gut. And the gut health plays a big role. So move to the next one, please. So agenda of today's meeting and this particular discussion is about metabolic health, the burden of metabolic syndrome or the syndrome X in our country, the risk factors, the root cause of obesity via the metabolic health modified with the help of gut microbiomes, the relationship between gut microbiome and the insulin resistance, central obesity, insulin resistance, vascular health, how they are closely related to each other, the gut dysbiosis in type 2 diabetes and the metabolic syndrome, PCOS, which is again one of the big things which we are facing, all of us, not only in the urban areas but also in the villages, and the gut microbiota, how we can use it to potentially reverse the metabolic syndrome. So going to the next slide. Shall I? Yes. So when we are talking about metabolic health, the metabolic health used to cover something which was related to the diabetes and the hypertension only few decades back. With the better understanding of the physiology and the interrelationships of various matters, we are able to now define it more precisely about blood sugars, the waist circumference or the central obesity, the blood pressures, the lipidemia or the cholesterol levels, triglycerides. If they are all within the healthy range, we call it as the good metabolic health. So what are these ranges? The ideal waist in men should be less than 40 inches, less than 35 in a woman, no traces of diabetes in the blood sugar. So this is about fasting blood sugar levels, postprandial blood sugar levels, glycosylated hemoglobin, serum insulin levels, fasting and PP both. If any of these are abnormal, either we are labeled diabetic or pre-diabetic. The third part is the normal blood pressure, where the systolic may range from 90 to 120 and the diastolic may range from 60 to 80. The fourth part is the lipidemia parameters. So normal blood fats or the good cholesterols or the protective cholesterols of HDL nearly 60 or more, LDL less than 100, triglycerides less than 150, and the total cholesterol less than 200. This is how the metabolic system should be. Even one factor changes, the metabolic health changes. And finally, it affects the vascular health of the body, which finally affects the organ health of the body. Next, please. So when we start moving from the healthy metabolic system to the diseased metabolic system, what happens? These are the various parameters which we talked about in the previous slide. Some of them change first and the rest of them change sooner. It never happens that a person has diabetes but he never landed up into hypertension. So what we call it as is a giant wheel of diseases. You sit in one car, you have to move through the rest of the stations. And this is how the metabolic syndrome affects the complete metabolic health of an individual. Some patients may come with the kidney troubles first, some can come with the fatty livers first, some may come with PCOS, some may come with frank diabetes, some may come with hypertension. And let us understand that every parameter has got a silent erosion of the body. So the presentation may not be like, I have the higher sugars. The presentation will be typically signs appearing at the later stage of the disease. So particularly when the patient has presented to you clinically with these symptoms and signs of diabetes, hypertension, cholesterol, it comes as a stroke, maybe chest pain, maybe obesity, but it will never come as a very initial stage of the disease. So in medical science, we understand the diabetes as the disease which appears with derangement of the sugars. It is the day when nearly 80% of the patient's insulin production system, that is beta cell, is already failed. So typically when these diseases are diagnosed, they are already at a pretty much later stage of the disease, because these are all silent killer diseases which keep on eroding the systems without us understanding. So even if you find one problem out of all these 5 or 6 parameters, try to dig out the other problems and do not neglect anything lightly. This is a very important message which I want to share with all my friends here, that metabolic syndrome is a major public health problem, personal health problem, affecting majority of the public in India, and its presentations are usually late. The sequence of events may be different, but everything happens in sequence for sure. It is a disease which keeps on escalating itself unless treated very particularly. It doesn't get cured on its own unless paid attention in particular and given the particular treatments. And it leads to a major economic setback to the person, to the family, to the society, and to the nation. So you will be very surprised to know that 60% of the healthcare economy in India completely is invested or vested or evolving around the complications only of metabolic syndrome. Forget the whole disease of the spectrum. So typically, this is something where we have to be very, very vigilant. Hypertension, low HDL, cholesterol, insulin resistance, visceral obesity, high triglycerides, each and everything is a part of a big disease, and let us not neglect it even at the glimpse of it. Next, please. So this metabolic syndrome was the name derived after certain changes. It used to be known as Revan syndrome initially. When Dr. Revan thought about all these things, not a different diseases, not separate singular entities, but a cluster of problems, which will invite the other siblings very soon. It was called as syndrome X sometime back. Sometime back it was called as deadly quartet metabolic syndrome, and now we call it as insulin resistance syndrome, because the key player in this system of metabolic health is the insulin resistance. This is the understanding of the science as on today. So that is where the treatments of obesity shifted from only eating less to making the better insulin resistance levels or improving them, make the body more insulin sensitive. The treatments of hypertension also started looking at this. The treatments of diabetes, from just controlling the high sugar levels, started moving to making the insulin resistance less. And this is something which is a revolutionary thing which we are experiencing in last almost 25 to 30 years, you can say. Next, please. The burden of metabolic syndrome in India, if you want to see in this slide, you will know that there is a consistent huge rise in the abdominal obesity. A time was there when India was a very malnourished country in terms of negative nutrition. Today we are a malnourished country in the sense of positive nutrition. It doesn't mean that it belongs to higher socioeconomic strata. We get the rickshaw drivers, we get even the street vendors, as well as the richest people in the world who belong to India. Still they are facing the similar problems. So typically, if you look at it, insulin resistance and metabolic syndrome are widely prevalent. Out of 5, 3 Indian people will be found to be suffering from at least one parameter, which means the whole syndrome finally. In urban India populations, overall, approximately 25% of the people were found to be with prevalence of metabolic syndrome, all 4 things present. And now we know we don't need all 4 things to be present on day 1. It can be only one single thing which is present, but then everything will follow soon. So typically, all these things shift to around, as I said, out of 5, 3 people suffering from the disease. 31% women and around 19% of men. Why the difference? Do we women eat a lot as against our contemporaries, that is the other gender? No. It is because of 2 things. Number 1, women tend to neglect their health a lot. So they will go behind their family members, but they won't look at themselves. Number 2, women do double duties, one in the office, one in the home. So the stress levels are pretty much higher and different. Number 3, the patients or the women tend to have, because of lot of hormonal turmoils they need to face throughout their reproductive age, they face quite a lot of hormonal imbalances. And that is one of the strong reasons why women face these problems. Consistently, we are finding higher women coming up with the disease than the men, but it is not less in the men, let me tell you. With increasing age, it is more, but again, in the last 1 decade, we have seen the shift to the lower age. So something that was common in 60s, some 30 years back, is now common in 40s. So new 20 is the old 40. This is what we are seeing. And this is something which is really a very, very disturbing factor. Of course, even though things are treatable, a large public education as well as the medicos and healthcare workers education is needed for all this control. Otherwise, it's an ocean of diseases. Next, please. The risk factors, as we understood, obesity, central obesity, the sedentary lifestyles, aging processes, presence of diabetes mellitus, maybe the IGTs or the high insulin resistances, CHD, premature CAD, and lipodystrophy. Now there is one wonderful thing which I find when I talk to public about this, even the learned public, okay. Once they feel that, okay, I had CHD, coronary heart disease, I underwent angioplasty, I'm taking some medicines, they forget that the rest of the vessel is vessel and the complete vascular health also is under stress. So CHD patient may not get stroke is not the good concept in their mind. So we have to keep on telling them that it is not the single organ disease, it is the disease of the complete vascular health of the body. Next, please. So coming to the gut microbiota and obesity. This is one subject which is very near to my heart. And way back in 2009 and 10, we conducted one study with the help of microbiology department in Pune University. It was about patients with obesity, patients with diabetes, and the same patients, when they undergo treatments, their comparison to the normal public. So you saw one American Association's best international poster award given to me in 2012. It was about this paper, where we found that normal people carry a certain type of microbiota. The species are specific, and when in obese people, in diabetic patients, they are totally different. Once they receive the treatment, they again start becoming normal. So this was one of the very initial papers which spoke about the gut microbiota and its association in diabetes and obesity. We had the similar observation which is seen here, that despite consuming the same diets, the lean people exhibited increased body fat accumulation, increased metabolic changes, and this was totally different than the people who were obese. But the same obese population showed the change towards normality when these people we evaluated their stool samples. The study was done with giving them a certain kind of food over some period. All three groups were given the same food patterns, and all three groups were studied with their stool examination. And the microbiology was found, or maybe you can say we were analyzing the microbiota levels in those stools. It was very interesting to find a certain pattern which was found in the normal people and the obese and the diabetics, and the two groups started mimicking the normal group once they were given the treatments. So this was one of the indications that gut microbiota influences the body weight and metabolism, and metabolism also influences the growth of certain microbiota. So it is a to and fro relation. Next slide, please. When we talk about the root cause of obesity, we understand that it is a multifactorial disease. Genetics plays a role, environment plays a role, behavior plays a role, food choices, your physical activity, your micronutrition level, your metabolic system. All these things play a big role in terms of converting a healthy body to an obese or the diseased body. Any specific changes are seen in terms of bacteria, metabolites, and host factor. This was one study conducted in the lean patients and in the obese patients. What we are able to find is lean patients showed high diversity, high gene count, high flexibility, as against the people suffering with obesity, which showed low diversity, low gene count, and low flexibility. This in turn led to decrease in the satiety signal of the body. So satiety became a later happening. So you need to feed yourself more to gain the satiety. Inflammation levels were very high. Lipogenesis was very high. So storage was more and the utility was less. Gut permeability increased. Fat accumulation in turn was high. Fatty acid oxidation came down and insulin sensitivity also went down. This all finally led to the atherosclerosis, the hypertension caused because of it, the fatty liver disease or the NASH, what we call it as non-alcoholic steatohepatitis, the cardiovascular disease, and the diabetes. Next, please. So talking about the insulin resistance, we discussed some time back that this is one of the preliminary factors which convert the complete story from a disease, from the non-diseased body to the diseased body. What is insulin resistance? Insulin is present, but it is unable to process the calorie to the utilizable form of energy. And that is where the calories keep on going in the storage account. Your sugars are high, your lipids are high, your fat percentage is high. All the factors secondary to this will become high. And normally, the work of the insulin is like the ignition in the car. So you put your fuel, your engine is okay, but unless and until the ignition works well, the engine cannot utilize the fuel. This is something which happens when we understand the disease of metabolic syndrome and the obesity. The elevated insulin levels, which are found in the initial phases of insulin resistance, indicate that they are unable to process the sugars in the physiological way. Typically, the pancreas has to run after the sugar to keep it down or normal with the help of higher levels of insulin. This typically will lead to high insulin surges, and the glucose, which may remain normal in the initial few years of the prediabetes, you are in fact wasting your insulin because it is been disproportionately high to the sugar that is consumed. This typically leads to a very high strain on the beta cells of the pancreas. And remember, the insulin has got half-life which is very much longer than the sugar. So typically we find when we eat something and after within half an hour or maybe within some time, we feel that we are hungry again and we want sweets. Why after having a full meal or having any food intake, your body should crave for that sugar? This is because the insulin levels are high. The sugar is now disappeared from the scene, but the insulin level remains high, and insulin is the hunger hormone. Typically, insulin, ghrelin, these are the groups which give you a higher hunger. And ghrelin works against the insulin. So when the ghrelin levels are high, the insulin resistance is high. Initially, insulin level will be high, but sooner the beta cells go into exhaustion mode, and typically the body is unable to keep the sugars normal. So that is why what we say is 1, fasting blood sugar more than 100, 2, insulin levels PP more than 80, 3, HbA1c more than 6. These should be the parameters which are indicating the underlying diabetes. So here we have described how the insulin acts in the abnormal condition. First important part, I'll get you to a short this thing out of this. 1,
Ma'am, sorry. Ma'am, sorry to interrupt, but we have another 5 minutes.
Yeah, I will finish it up. Okay. So typically, insulin will increase the hunger. It is one of the very, very highly inflammation inducing agents. So in the pre-diabetic stage, in the hyperinsulinemia stage, you will get the highest vascular damage. So do not neglect this phase for sure. Can we go to the next one, please? So that is why always and always with insulin resistance, you will find bad vascular health and atherosclerosis. What is the relation between this gut microbiota and insulin resistance? Glucose metabolism impacts the immune system. It impacts the gut microbiota and it impacts the glucose metabolism again. This is happening through the immunomodulation, happening through the inflammation, which is fueled because of this insulin resistance. And typically, this will invite adipose tissue and sugars to get accumulated, finally leading to fatty liver, which itself is a strong indication of insulin resistance. So my request to all of you is do not neglect fatty liver. It is one of the early precursors telling you that many things are going wrong and you should start acting at that point. Next, please. How the central obesity leads to coronary heart disease. There is a proverb which talks about the bigger the waist circumference, shorter is the length of life. Why so? because bigger the waist circumference, bigger the hyperinsulinemia, as we discussed some time back, bigger the dyslipidemia, bigger the atherosclerosis, bigger the bad vascular health, and this leads to finally coronary heart disease, as well as the multiple vessels of the body which are going wrong in a very fast way now. And there is a reversibility to certain extent, but better we start early so that we reverse the disease as soon as possible. Next, please. So, role of this gut microbiota in the cardiovascular disease. Dysbiosis leads to this leads which gets associated with the increased cardiovascular risk because they promote the atherosclerosis, and platelet hyperreactivity means clotting mechanism becomes stronger. Atherosclerosis is what? The typical vessel gets lot of disturbances or lot of irregularities inside. The endothelial damage is high and leads to clot formation. There are certain gut microbes which can influence the blood pressure regulation through the production of bioactive compounds like the short chain fatty acids and the nitric oxide. These are the compounds which impact the vascular tone, the endothelial damage reversal, and this can help us in betterment in the pressure of the complete vascular system of the body. Next, please. In type 2 diabetes, how the gut dysbiosis works. There is diet, there is symbiosis, which works improving the gut motility, improving the satiety, improving the insulin sensitivity through the immunomodulation. And when it goes into dysbiosis, typically everything goes wrong, and typically we are landing up into steatosis, the fat accumulation. This impacts the insulin sensitivity and glucose metabolism. Modulation of the lipid metabolism can be very highly impacted through the gut microbiota because this will impact the lipid levels, this will impact the insulin resistance and the diabetes occurrence, all those things. There are some identified incretins like the GLP-1s, which improve the insulin secretion and glucose control. So GLP-1 analogs help us in the control of diabetes. All these things, ghrelin, insulin, leptin, GIP, GLP-1, PYY, all these are the various incretins secreted by the digestive system, and they play a major role in terms of occurrence of the metabolic syndrome. Now, all these things work in a symbiotic way or like an orchestra. So if we modify one thing, many other things can get modified. And one of the big roles which our bariatric surgeries play in the patients for reversal of metabolic syndrome is via the incretin modulation. Now, once we did the bariatric surgery and do the incretin modulation of the patient, the gut microbiota starts working in a symbiosis way. And now it is the patient's responsibility that the disease by the body is under control. They should be able to identify the right foods and go into a symbiotic way. That chain needs to be helped by the patient. Next, please. PCOS, as again we saw it, it is the second outcome of insulin resistance. First one is glucose dysmetabolism. Second one is PCOS. So that is why PCOS should not be treated at the ovary level. It has to be treated at the climate around the ovary, which is governed by the metabolic syndrome. So that is where now the PCOS treatments have come out of the ovary centric treatments towards the metabolic centric treatments. Next, please. Now we are coming to the last few slides, and it talks about micronutrient absorption. So here it is very interesting to know. This is a very, very busy slide, but try to understand how it works. Now you will know the microbiota which are within the gut help us absorb the water soluble vitamins, the fat soluble vitamins, the short chain fatty acids, many other things which we really do not need. For example, there are some kinds of microbiota which will absorb heavy energy from the food and give it to the host. And there are the similar ones which will give very less micronutrition absorption. So typically you will find the paradox in all obese patients. They are having macronutrition, which is a disturbed one, heavily accumulative, heavily absorptions are leading to this, and micronutritional deficiencies are a part of the story. So typically there are certain microbes which will hinder the absorption of micronutrition, but help you have the heavy energies absorbed. We have to understand that gut microbiota plays a role in maintaining the integrity of the gut barrier, which is very, very important in terms of optimal nutrition absorption. The gut microbiota modifies the bile acid metabolism, impacts the absorption of all vitamins, as well as other minerals like iron, calcium, magnesium, and zinc. And not only absorption, but the mineral bioavailability to the host is dependent on the gut microbiota. Now, when we are talking about all these things, we cannot forget that what we eat same which we used to consume 30 years back. The use of multiple insecticides, the fertilizers, the kind of quality and the mineral quality of the water, the kind of quality of the sand, or maybe the farm, all these things have changed a lot over the last few decades. And that is where we are going away from the symbiotic relation with the gut microbiota. We have to identify the right ones. We have to improve those levels in our body. Otherwise, only treating the disease at one end and not looking at the multiple root causes, we can never win over the diseases. It is very important to know that microbiota, we must go hand in hand in a symbiotic relation if we want to win over all these diseases related to the gut health. Thank you very much. And I hope I could give some more insights about the problem and the association with gut microbiota. Thank you, IDA.
Thank you very much, ma'am, for a very insightful talk. Without much ado, I would like to immediately start the panel discussion. May I request all the panelists to start their videos. Salome ma'am, please could you start your video?
I'll call Ma'am Sheetal. You start.
Thank you. So very good evening. Thank you very much, ma'am, for a very insightful talk. I think all of us have, we've learned a great deal. One of the great insights was that gut dysbiosis does lead to and possibly has a connection with obesity, CAD, type 2 diabetes, and PCOS. And definitely having a healthy gut could help us reverse the incretin modulation that is there. And with that, we'll move on to the first question for Dr. Tolkar, and that is, what are the nutritional compliance challenges for sustained results after bariatric surgery?
Hello.
Hello, ma'am, can you hear me?
The last, what are the nutritional?
What are the nutritional compliance challenges for sustained results after bariatric surgery?
Very important question. We need to actually educate the patients well that yes, some part of your problem will get sorted with the bariatric surgery, but to keep the things on and get the benefits on the long-term basis, we have to dietary education and the physical activity regularity. There are some compliance challenges which can be sorted or which can be solved with the help of the support groups. But we do find them. Number one, if you do not prepare the patient about how the operations work and why it is not the only single entity which can reverse the whole story, we need to tell them about what are the expectations from them in terms of diet, exercise from the after surgery. Number two, we evaluate their complete nutrition before, and they have to be continuously having those supplements through the life. Why? Because as we saw it in the previous slides also, there are absorption defects in the body. And it is a chain of multiple chemical reactions. So significantly keeping your micronutritional level stable is very important. Whether you undergo bariatric surgery or not, still it is important. Number two, we cannot on the natural resources, we cannot depend fully because of some reasons which we discussed. So the challenges are sometimes patients feel that, okay, you have done surgery, now it is not my responsibility to do anything from my side. So that is a big myth that we need to remove from their minds, and giving them understanding about the habits towards the food and the relation of their mind towards the food is very important. Sometimes patients are using food as their one of the escape factors. Some skips, some relieves, their mood changes. Here we have to make them understand, go into their psychology, because mind, psychology, nutrition, they work together. So typically a malnourished body cannot think better. We have to give them that understanding. So there are multiple challenges in terms of many myths, many things they Google themselves and try to exacerbate the outcomes. All these things can be helped by patient education. And touch wood, since 2005 till today, we have found a good result because we invest a lot in terms of patient education, pre and post both.
Okay, thank you very much, ma'am. My next question is Neeti ma'am. Neeti ma'am, as we have seen that PCO and with Neeti ma'am, allow me to introduce her. So Neeti ma'am is a very experienced and very senior consulting nutritionist who's been practicing in South Mumbai. She's been with Kambala Hill Hospital for 17 years. She is a secretary and master trainer at the Association of Diabetes Educators, and I have been very fortunate to study and learn under her. She is the co-editor for the Indian Dietetic Association's Clinical Dietetics Manual, published in 2018. She is the Joint Treasurer for IDA Mumbai chapter. She's a regular columnist in health and nutrition for the last 18 years. She's also been the official nutritionist for Feminamis India in 2008. Thank you so much, ma'am, for being here with us. We truly appreciate it.
My pleasure.
Ma'am, my question is on PCOS. PCOS is very closely linked to early puberty. Do you recommend when treating patients that we should focus on gut microbiome modulation for teenagers to maybe help prevent the onset of PCOS?
Thank you, Sheetal, for the kind introduction, and thank you for having me here in this August panel. Yes, as Dr. Todkar mentioned, that PCOS is just another manifestation of insulin resistance, and there is enough data which shows that gut dysbiosis is associated with insulin resistance. Also, in fact, there have been studies where the fecal microbiome, the fecal transplantation from a PCOS woman, when done in mice, experimental mice, what was seen was that there was development of ovarian dysregulation, immune changes, which basically leads to a chronic inflammatory state, development of insulin resistance, and also disruption of the bile acid synthesis, which again we saw in the previous presentation affects the absorption of fat-soluble vitamins. So all in all, there is, of course, gut dysbiosis in the initiation of PCOS. Also, we know there is a correlation between obesity and PCOS, significant correlation. So the teenage years, especially in our current scenario, where the girls are perhaps not eating the healthiest, are taking in a lot of empty calories, processed foods, are not getting the enough macronutrients, and more importantly, even micronutrients. Also, processed foods will be devoid of probiotics, prebiotics. So yes, I think it's a great opportunity at this age group to intervene. First of all, improve the overall quality of the diet, and then also look at foods which are prebiotics, probiotics, or as we call them, symbiotics.
Thank you very much, ma'am. Ma'am, once the onset, I have another follow-up question, ma'am. Once there is an onset of PCOS, while planning diets, focus definitely on the macros, and we focus on a healthy eating plate, are there any key micronutrient supplementations that you would recommend?
Right. So, as you correctly said, first we look at the macros, the calories, but there have been enough studies, sufficient studies, which are showing that there are some key micronutrients which are very, very important in the overall treatment plan of this complex heterogeneous disorder, which is not very easy to treat. So there's a lot of evidence for inositol. There is evidence for melatonin. When we are talking about micronutrients, if you're looking at vitamins, then again, vitamin D, we know it has a direct correlation with insulin resistance. Vitamin D is important, and even evidence is there for vitamin E supplementation. When we are looking at micronutrients in terms of minerals, we have evidence for selenium, zinc, chromium, and in fact, all the antioxidant ranging from NAC, that is N-acetylcysteine, to carotenoids, which basically work on the inflammatory state, on the oxidative stress, and help in the treatment of PCOS. Omega-3 also has been studied, and even the role of probiotics and prebiotics is also being studied.
Thank you. Thank you very much, ma'am. I'm sure that was a great learning, and all of us are going to be looking into our PCOS diet planning a little differently from now on. Thank you, ma'am. My next question is for Salome, ma'am. Ma'am, which is the key micronutrient that must be supplemented for patients on metformin?
Thank you, Sheetal, and hello and happy Nutrition Month to all of you. Yes, coming right to your question, it is the evidence suggests B12 should be supplemented for all those who are on metformin because it hinders the absorption of the B12. But as Dr. Todkar rightly said, that the gut microbiota doesn't allow the absorption, utilization, and also there is more of excretion with the diabetic patients' gut microbiota. And when we see then when these patients take so many tablets, medications, so the medications changes the gut microbiota. So when that comes for every medication you take, whether it is hypertension or a cardiac or a diabetes, and therefore not only B12, I would say that we should supplement ourselves or those who are suffering from type 2 DM and other metabolic syndrome from all the even minerals and the micronutrients, sodium, potassium, magnesium, calcium, selenium, zinc, and B complex vitamin, because many of them are on statin also, which again does not allow B6 absorption. So it's not only a particular nutrient, but I say you improve your microbiota and then you take carefully the medications, and there should be a interval. You know, some medications to be taken with the food, some before food, and some after food. So that is why when we are taking it with food, we have to be careful and take our dose of required micronutrients as a supplement.
Thank you very much, ma'am. Ma'am, but then are there any other OHAs which, when taken, definitely we should be careful for any micronutrient supplementation? Like for metformin, it is very clear that we should definitely look at B12 supplementation. When we are taking any other OHAs, is there any recommendation?
Not OHA per se, but diabetics are also on statins. So with statin, you have to take B6. That's a B complex vitamin you need to take. And B12 specifically because it hinders. But we have the group of B vitamins together. And when we see their levels of diabetes, we do see the levels being low also of the other minerals. So magnesium being very low for the diabetic patients. So we need to supplement magnesium. So calcium, magnesium, and selenium, of course, because we need selenium for so many other functions, cell metabolisms. So we need to take, we are not meeting the requirement, and even if we are meeting the requirement, because either it is not absorbed or it is excreted because of the drugs.
Right. Thank you, ma'am. Thank you very much. My next question is for Zamrud, ma'am. Ma'am, what is the prevalence of iron deficiency anemia in CKD patients? And when should we supplement and how much?
So, as you know, iron anemia in CKD patients is a part of the disease process. Basically, if you see early stages of people with chronic kidney disease, you may not see this deficiency much. Anemia may not be markedly visible. But as the stage of chronic kidney disease advances, the anemia is more common in them. And if you see, basically, only supplementation of iron may not be helpful in this population, because you need to understand that kidney plays a vital role in making for you erythropoietin, which helps in the synthesis of your RBCs and that builds your hemoglobin, right? So if you only keep feeding the person iron, it may not help the person. But you definitely need to look at the stage of the disease and then make your nutritional prescription. A balanced diet in terms of, even when I talk of adequate amounts of iron, needs to be given to all stages of chronic kidney disease, but probably in the advanced stages, you may need supplementation. So you need to have this in mind, because anemia needs to be treated in this population. Otherwise, it makes them more prone to cardiac problems. The load on the heart would increase.
Rightly so. I think that is something that we always struggle when planning with renal diets, about having the foods nutrient dense. I have one more follow-up question for you, and that is, how would a diet which is focused on gut micromodulation, and if it's possible, this is an ideal scenario, that a diet on gut modulation along with micronutrient supplementation, would it, if at all, help in delaying the onset of CKD?
So you're absolutely right here. Okay. So you see dysbiosis even in patients of chronic kidney disease. There is enough literature to show you that you do need to give adequate amount of fiber to these patients. Okay. In chronic kidney disease, basically the problem that we see is we try to control the electrolytes, and in the compromise, you're restricting the fiber portions of the diet. So you really need to feed adequate amount of fiber to these people. That's very important. And again, using of supplementation, if there is a need, there should be no hesitance of using any type of supplementation, but you need to check the biochemical profile of the patient. That's very important. What you can give through the diet, it's always better to give through the diet. If not possible, then use supplementation. That's important.
Great. Thank you. Thank you very much. Sorry, Samrat, were you saying something still?
No. I was just saying that you definitely need to add fiber to these diets, which most of the times we miss. That's very important, because somebody will say, oh, potassium needs to be restricted. Don't use fruits. Don't use these leafy vegetables. Don't use this. Probably there's a way of incorporating all these foods in the person's diet, but you need to do your homework very well with the biochemical parameters first.
Could you share? I have one more extra question for you, Samrat. Since you said that, okay, you should include it, but could you at least share with them how do you do it? I am
So
sure
for-
everyone
so I'll tell you very honestly, I first go by the biochemical parameter. If somebody has a normal potassium, and those the drugs which are used for these people, the ACE and the ARBs, to control their proteinuria, because most of the time in chronic kidney disease, you will find proteinuria. The drug would be responsible for the high potassium, not the food. That's the first thing. And even if the potassium is high, you can tell them to leach out the potassium. You can use the low potassium food which is available. You can calculate and give them the portion sizes of the food. Like if leafy vegetable can be incorporated, why not leach it and use it? Seasonal availability is another thing. Choice of the patient is most important. So you can definitely add variety to these diets also, which are supposed to be very restrictive. Okay. And you can definitely let the patient enjoy the food. That's very important. And one more thing I would like to highlight here is that all people with chronic kidney disease, even in advanced stages of chronic kidney disease, may not require potassium restriction. So if the serum potassium levels are normal, don't restrict potassium. But if there is a need, then definitely we can restrict it.
Great. Thank you so much, Zamrud. Yes, definitely adding fiber has a host of benefits of short chain fatty acids, branch chain amino acid production. That does happen naturally and is beneficial for sure. Thank you so much for sharing the pro tip as well.
Thanks.
Eileen, thank you so much for your patience. I'd like to take a moment to introduce Eileen. Eileen is the head of dietetics at the Sir H.N. Reliance Foundation Hospital. She's been a practicing dietitian since 1997.
That's
She's also
okay.
a
That's
dietitian.
okay. Please just ask the question. It's okay. It's fine. I think everybody knows me.
Great. Thank you so much, Eileen. Everybody does know you very well. Eileen, thank you so much for being here. My question to you is, how is the gut microbiome impacted for patients in chronic critical care?
In
Chronic critical care.
critical care. Okay. So, first of all, the microbiome in a chronic critical care patient is actually continuously being assaulted by the disease itself, assaulted by the iatrogenic effects of the clinical interventions, by the antibiotics, by the medications, and it actually affects all the aspects of the gut, all the elements, like even the epithelium, the mucose. It affects the immune system. The microbiome health per se is profoundly altered with these kind of treatments. So these kind of insults to the gut, it could be a local injury, or it could be with different organs, because we know now that the microbiome is we talking about the entire microbiota, and microorganisms form a part of every system in your body, right from your skin to your gut. So it's not only the guts. And in critically ill patients, there is severe disturbance of this microbiome. Now, there are many factors besides the endogenous factors. There are factors like gastrointestinal dysmobility. There are shifts in the pH values of the patient also. Also, there is so much of production of catecholamines, treatments with antibiotics. There is also PPIs, that is the proton pump inhibitors are used, opioids are used, enteral nutrition is used. Sometimes the food is not digested well. So there is kind of, in critical care, we look at dysbiosis. And there is a specific growth of microorganisms, which really affects a lot in the outcome of the patients. However, we still are waiting for a lot of work to be done in this area to determine how we can improve the gut microbiome of a chronic critically ill patient.
So I mean, when we have a chronic critically ill patient, we do expect an overgrowth of the unhealthy bacteria, so to say. Then would you recommend strongly pro and prebiotic supplementation, along with definitely in first meeting our macros and micros?
Okay. So macronutrients we are meeting, we are looking at, the entire focus is on calorie, protein, and total targets. Sometimes, we do forget that micronutrients are also an important part of this thing, because we just take it for granted. It's like the secondary, a stepsister treatment that's given in the ICU, which actually it's primary, and we should look at it very, very carefully. And, we all wake up when there is something sudden that happens, like if the patient has diarrhea, then we say, are we giving fiber? If the patient has some other, say skin issue or something that way, and then we say, are we giving omega-3? If the patient comes out with something with immunity, then we try to look out, are we giving all immune nutrients? If there is a wound, like a bed sore, which is not healing, and that's when we think, how much zinc is the patient taking? So, sometimes we have like a knee-jerk reaction, like, yes, there is a symptom, then we are wondering. But I think what's more important is that we have to proactively look at giving these things, not only our micronutrients, not only zinc, selenium, glutamine, and everything else, but closely looking at the gut of the patient. So these days we are looking at the fiber part of it, and there are a lot of supplements which are now coming up with pre and probiotic. There are supplements coming with FOS. There are also just guar gum kind of supplements that have come out. So it's not that, it's just being neglected. It is definitely looked at in specific situations where you need the production of short chain fatty acids, you need the production of galacto oligosaccharides, fructo oligosaccharides, and these are looked at. Now, the problem here is the safety issue, because the practical issue is the dosage. What is the dosage? How much should be given to these patients? What is the treatment duration that has to be given? Also the timing, what time to give? What is the effect of it with a particular antibiotic? So lots of questions in mind, which which we just feel, yes, it will get resolved. But I think a lot of specific stress on research in this particular area needs to be looked at. And we need to also shift our research from calorie, protein to micronutrients and pre and probiotics.
Yes, thank you so much, Ivy. I remember at MICU rounds at Nayan Hospital, and we used to get a lot of questions on micronutrients from Salome. So it was definitely ingrained that, okay, this patient has got respiratory issue. Have you given magnesium? Yes or no? And if not, then yes, we definitely had to make sure we've corrected and not repeated it. So true, micronutrients definitely do play a key role, and they definitely do improve patient outcomes in critical care settings. So with this, I would like to summarize our panel discussion. First and foremost, thank you very much to all the panelists. Thank you so much for being here and taking out your precious time to be here. We've learned immensely from Dr. Tolkar that how incretin modulation is there in bariatric surgery, and therefore it leads to a reduction in NCDs. However, micronutrient supplementation and nutrient-dense foods are the key to better outcomes, along with counseling. Thank you so much, ma'am. Then we've also learned from Niti ma'am that along with a very heterogeneous diet for PCOS, we must make sure that we have vitamin A, D, E, C supplementation along with micronutrients of selenium, chromium, and zinc, and focus on omega-3 along with definitely pre and probiotics that has been consistent across all speakers. Then with Salome ma'am, we've learned that whenever we have a patient with metformin, we must ensure that B12 supplementation is there. And with statin, we must have B6 supplementation. Zabrut, thank you so much for your key tip on making sure we include green leafy vegetables for our patients and we don't restrict them for CKD patients. And we also ensure that with dysbiosis, we make sure that they're having seasonal vegetables and we keep in mind the drugs that they are having and ensure that we feed our patients a variety of diet. And thank you so much, Eileen. Definitely, we're going to be focusing on the micronutrients and not letting them be left far aside.
Thanks.
Thank you so much, everyone. I'd like to now call upon, I'd like to take maybe just about 2 or 3 minutes to share briefly about Superfoods Valley and then hand over to Sukhida. Before I begin, allow me to thank IDA Mumbai chapter for the opportunity to collaborate for the National Nutrition Month. A very brief introduction about Superfoods Valley. We are a startup and we're based out of Bangalore. Our entire mission to start Superfoods Valley came from the need to beat hidden hunger. That is the micronutrient deficiencies that are prevalent in India. More than 2 billion people worldwide have micronutrient deficiencies, and 8 out of 10 Indians are known to be micronutrient deficient. It is there throughout the life cycle, starting from low birth weight, stunting, to increased fatigue, to increased mortality, reduced productivity, malnutrition, and increasing the risk of chronic diseases. The menace of anemia in India is widely prevalent. More than 50% of the population across all cohorts has anemia. There is an increasing trend in men and women both having an increased anemic profile. Across India, there is a zinc deficiency which is observed in 19% of children in school, whereas 32% in adolescents. The 6 key vital micronutrients that are deficient in India are vitamin A, B12, D, iron, iodine, folic acid, and protein, of course. We have seen that there is an increased rise in micronutrient deficiencies in the urban population when compared to the rural population. And that could be because of lifestyle factors. It could be because of faulty selection of food habits, high food prices, and definitely impaired absorption because of a poor gut. The solutions for this are biodiversity, fortification, and supplementation, along with improved hygiene. Our expert scientific council has helped us develop the products. We have Dr. Shashikaran, we have Dr. Krishnaswamy, we have Malika ma'am, we have Dr. Chauvin, and we have our very own Sheila Krishnaswamy ma'am. They are on the scientific council and have helped us develop and envision this product. So why this? Why do we have a nutrition mix? Well, it has been observed that multivitamins tablets are considered to be more, multivitamins tablets, they're considered to be difficult, low compliance. Then when we go into when we go into formats which are add to food, it could be because that they have higher sugar, so therefore parents prevent or try not to give it now with increased awareness of sugar. Gummies and strip make it exciting, however, they are not very compliant as well. So therefore, we have a nutrition mix which is more of add to food. It's almost like you're eating your food and making it nutrient dense. It has no added white sugar, no added salt, no added fat, no added preservatives, and 4 kilocalories. How is this being done? It's a very scientifically designed product. It has a key ingredient called lysine, as we are a carbohydrate-based nation. Lysine is the building block that is missing in our cereals, and therefore lysine has been added. So we're improving the protein quality of our food. At the same time, we are ensuring we have a symbiotic relation with pre and probiotics. And we also have the key micronutrients being supplemented in good milk. That is vitamin A and D as fat-soluble vitamins, B6, B9, B12 for water-soluble vitamins, along with vitamin C. And then we have iron and zinc as well. Iron, we have sodium EDTA, that is there, which is highly bioavailable, and we have zinc sulfate. Both are highly bioavailable and well absorbed. For probiotics, we often have a question as to which one do you have. Well, we have phos for fiber, and for probiotics, we have bacillus coagulans, which is spore forming. Therefore, it will survive the hot temperature of the food. Along with it will also survive the acidic nature of the gut. So lysine, as I've said, since we are a carbohydrate-based nation, we have focused on that. For probiotic, we have bacillus coagulans. And what is the mode of action for phos? Phos is extremely beneficial. However, if a patient has a sensitive gut, it is always recommended to start small, as it is part of our FODMAP diets. And it is recommended to start it with only 1 sachet a day at night. Yes, the symbiotic effect is very definitely helpful. And it has shown that even though we are giving bacillus coagulans, the fermentation of fiber has helped increase the permeates and the lactobacillus species in the gut. Well, we also have a Healthy 50 Plus, which is a new product that we recently launched. How is it different? Well, it has A, C, and E selenium, and along with that, it also has chromium for improved insulin sensitivity. We also have biotin and folate along with vitamin K. And we continue to have lysine, ashwagandha, and brahmi. We recommend it for adults who would like to be 50 or who are already 50 and would like a Healthy 50 Plus. So without taking much time, I would like to hand over to Sukhinder for the vote of thanks.
Thank you so much, Sheetal. I think it was a very well curated program, and you did it bang on time. I would say it was a food for thought. All the speakers and the panelists, right from Dr. Jayashree Todkar, who set the stage with metabolomics and gut microbiome for how it affects the different non-communicable diseases. If we think of it, gut microbiome is not only affected by the diet, it could be affected by your environment. It could be affected by your sleep pattern. It could be affected if you take too much of stress, if you stay up late, if you smoke. So apart from diet, there is lifestyle as well that can affect the gut microbiome. And it not only can be a reason why you would have an increased risk for non-communicable diseases, but as a result of an underlying NCD, you may have a poor gut microbiome. So it's a vicious cycle that we see, and a lot needs to be corrected if you need to correct your gut microbiome. It's not a simple answer where you can just look at a pop-up pill and correct your gut microbiome. You need to work on a holistic approach, and which is what the theme for this year's National Nutrition Month is. And I'm really glad that we started with this program, set the stage where we spoke about different aspects of metabolic health which are affected because of poor diet. So let me take this opportunity to thank Dr. Jayashree Todkar, our panelists, Ms. Salome Benjamin ma'am, Ms. Neeti Desai ma'am, Dr. Eileen Tande ma'am, and Ms. Zamrud Patel ma'am for taking time out of your busy schedule to come and share your insights, share your valuable experience with our participants. Sheetal has been an integral part of IDM Mumbai chapter, so let me thank her for wonderfully deliberating the panel discussion. And also as a part of Good Monk, let me thank the Good Monk team for sponsoring this event. Thank you all the participants for your patient hearing, and have a good National Nutrition Month.
Thank you all. Thank you very much, Sheetal, for having us here.
Thank you, Zamrud. Thank you so much.
Thank you very much. Have a good weekend.
Same to you.
Dr. Todkar.
Yeah. Okay. Bye.
Bye all. Bye.
To everyone. Thank you.
Bye.
Bye-bye.